Today, we're diving into one of the most critical aspects of neurosurgical patient care, perioperative antibiotic prophylaxis. In our field, a single microbe in the wrong place can be absolutely catastrophic. So we're going to break down the science behind it. This is the evidence-based strategy we rely on to shield our patients from devastating surgical site infections. It's truly a game of timing, precision, and knowing exactly which tool to pull from the toolbox.
This statement really hits the nail on the head. When we're operating on the brain or spinal cord, any breach of that sterile barrier, well, the pound of cure that follows could mean permanent neurological damage, or even worse. So our prophylactic choices, they aren't just about following protocol. They are the active first line of defense, protecting the most critical real estate in the entire human body.
All right, so here's how we're going to tackle this. First, we'll lay down the foundational principles. Then, we'll see how they apply to different types of procedures, both clean and contaminated. After that, we'll get into the tricky stuff, like navigating special scenarios with allergies, and finally, we'll talk about what to do when things go wrong and how to manage post-operative complications.
Okay, let's start at the beginning with the foundational principles. Think of these as the absolute rules of engagement that govern every single prophylactic decision we make, no matter what the surgery is.
So there are three non-negotiable pillars here. First, timing. The antibiotic absolutely has to be in the tissue before the first incision. That means we're giving it about 15 to 60 minutes pre-op. Second, drug choice. We have to target the most likely invader, which usually comes from the patient's own skin. We're talking about Staphylococcus aureus. This makes a first-generation cephalosporin like cefazolin our go-to workhorse. And third, duration. And this is so important. Keep it short. Pushing prophylaxis past 24 hours doesn't actually improve outcomes, but it does breed resistance and raises the risk of other problems, like C. diff. So the takeaway is pretty simple. Right drug, right time, and know exactly when to stop.
In this right here, this is why that timing is so critical. The entire goal is to keep the antibiotic levels in the tissue above this magic number, the minimum inhibitory concentration, or MIC. It's like a protective shield. If those drug levels drop below the MIC while the surgical site is open, that shield fails and we're exposed. So how do these principles actually look in practice? Let's start with what we call clean procedures. Think of a standard craniotomy or a spinal surgery for a herniated nucleus pulposus, surgeries where we aren't intentionally entering contaminated spaces. For these clean cases, the protocol is beautifully simple. The main threat is that skin flora, specifically Staphylococcus aureus. So a single targeted dose of cefazolin given right before surgery is the standard of care. It's a perfect example of our principles in action, a targeted drug given at just the right time and for the shortest duration possible. But, what happens when things don't go exactly as planned? Let's take a really common clinical question. What if a surgery, say a complex spinal case, stretches out beyond 8 hours? How do we adapt our prophylaxis then?
Right. For these long procedures, that single pre-op dose just isn't going to cut it. We need to extend our coverage for up to 24 hours after the operation. While still in the OR, we can just redose the cefazolin. Then, post-operatively, assuming the patient has normal kidney function, switching to a 3 times a day regimen like cefuroxime is a really practical way to make sure we keep those antibiotic levels above the MIC for the whole high-risk period.
Now, let's shift gears and look at a more complex scenario: contaminated procedures. A classic case study here is transsphenoidal surgery. In this case, the surgical path itself forces us into a completely different prophylactic strategy.
See, the approach here dictates everything. Unlike a clean craniotomy where we're just worried about skin flora, a transsphenoidal approach means we are literally traveling through the sinuses, and that introduces a whole new cast of characters. We're talking about anaerobes, bacteria that don't need oxygen, plus streptococci and other bugs. So our antibiotic coverage has to be much, much broader. To cover this wider range of pathogens, we need combination therapy. So we keep our cefazolin to cover the gram-positives like S. aureus, but, and this is critical, we add metronidazole. The metronidazole is absolutely essential for targeting those anaerobic bacteria that live in the sinuses. This dual-agent approach is the undisputed standard of care for this kind of procedure.
And just like we saw with clean procedures, that extended duration protocol still applies. If a transsphenoidal surgery runs long, past that 8-hour mark, we're going to continue the prophylaxis for up to 24 hours post-op. But the key thing to remember is that both agents, the cefazolin or its cefuroxime substitute, and the metronidazole have to be continued for that full duration.
So far, we've been talking about pretty ideal scenarios. But in real clinical practice, we're constantly running into exceptions. So let's talk about those critical what-if situations, specifically beta-lactam allergies and the ever-present threat of resistant organisms.
Okay, so what if your patient has a documented severe allergy to penicillin or cephalosporins? Well, ceflazolin's obviously off the table. Our go-to alternatives are either clindamycin or vancomycin. And it is vital to remember, if this is a contaminated procedure like a transsphenoidal, you still need that metronidazole to cover the anaerobes. The allergy doesn't change that part of the equation.
Another huge challenge is MRSA, methicillin-resistant Staphylococcus aureus. If we know a patient is colonized with MRSA, cefazolin simply isn't going to work. For these high-risk patients, we have to pivot. Vancomycin becomes our primary prophylactic agent right from the very start.
Now, despite all our best efforts, complications can still happen. So let's talk about how we manage one of the most feared, though thankfully rare, complications: post-neurosurgical bacterial meningitis. At this point, we're shifting gears from prophylaxis to active treatment. And just to put this risk into perspective, the incidence of bacterial meningitis after a craniotomy can be as high as 1.5%. Now, that might sound like a small number, but given how devastating this condition is, it really underscores why our prophylactic measures are so incredibly important.
If we even suspect meningitis, we have to treat empirically and immediately while we wait for cultures to come back. The regimen has to cover both Staphylococcus and gram-negative bacilli, those bugs that are common in hospital settings. This means using powerful combinations like flucloxacillin plus ceftazidime or a broad-spectrum agent like meropenem. But notice the critical modification here. If the patient has a CSF drain in place, the risk profile changes. That hardware can be a magnet for infection, especially with resistant organisms. So we have to add vancomycin to the empirical regimen for more robust coverage.
And it's just as critical to know when not to use these antibiotics prophylactically. While we treat post-op meningitis aggressively, the evidence is clear. Giving prophylactic antibiotics for things like non-operative skull base fractures or closed head injuries does not prevent meningitis. Making that distinction is absolutely vital for good antimicrobial stewardship.
And that really brings us to the core of our responsibility. Every single principle we've discussed, from that precise timing and targeted drug choice to keeping the duration short and knowing when to withhold treatment, it's about so much more than just one patient. It's about balancing immediate safety with our collective long-term fight against antimicrobial resistance.
And so I'll leave you with this final question to think about. The principles we've covered today are based on the best evidence we have right now. But as bacterial resistance continues to shift and evolve all over the world, our strategies have to evolve with it. This is not a static field. It requires constant vigilance, local surveillance, and a real willingness to adapt our protocols so we can protect our patients tomorrow just as well as we do today.